All right, 103. Um, let's jump right in. Um, Thank you to the PCBH SIG for accepting my request. I reached out and I said, "Hey, can I get a slot sometime in the next few months to talk to my fellow PCBHers?" And the leadership was kind enough to say, "Yeah, we've got some space coming up." So I appreciate that. My name is Neftali Serrano, if you can roll your R's and do the accent on the I, or Neftali Serrano is fine as well. I am the CEO of CFHA. We're the Integrated Care Association, and a lot of us are in the PCBH world. So today I'm going to be focusing in on PCBH, where I see it from my vantage point, and I'm going to talk a little bit about that from a personal standpoint, because I think personal story is helpful. But also, obviously, in my role as CEO, I talk with folks nationally all the time as part of my job every week. We also have an extensive technical assistance service, so we're on the ground, boots on the ground, helping stand up PCBH programs. In fact, right after this, I'm getting on a flight to head down to South Carolina to work with a clinic there to help them stand up their PCBH program. So we're doing that kind of stuff all the time. So that learning is what's informing this presentation today. But I'm presenting in a way that I hope um, spurs some conversation, spurs some ideas, and I'm open to be challenged on any of the assumptions here. So please feel free to challenge what I'm saying and or add your own insights to it. So let's jump right in here. My hope is that we can get through this with plenty of time to have conversation. Um, so we'll, we will give that a shot here. So this is the title of my talk, The State and Future of PCBH. For those of you that don't know me, I have been a PCBHer, a lifelong PCBHer. I've been working in the PCBH model from the very beginning of my career, now about 24 years ago. Um, and so I have a lot of history with the model of care. I have a lot of history with implementing the model of care, both from a clinician standpoint and also from an implementer standpoint. So I'm excited to talk to you about this topic for sure. Let me give you a sense of like where that um, journey has taken me, just as background to what we're going to talk about today. So, I started out my career in 2001 at a federally qualified health center on the west side of Chicago, and I knew nothing. I literally knew nothing. I was right out of grad school, so I very much knew very little about anything, but I especially knew nothing about primary care. Um, I honestly probably didn't even know primary care existed as a thing. I mean, I probably had heard the words, but I didn't have any reflective thinking around what primary care was in the healthcare system. And I certainly didn't know what PCBH was because PCBH actually didn't exist as an acronym. At that time, the model of care that I came to learn while in that position in Chicago was called the behavioral health consultant model. That was the naming convention that we used at that time. So the BHC model. And there were no books, no real references. The thing I found during my time there in a lit search was like one article by Runyon and colleagues out of the Air Force. That was it. So there's a lot of bootstrapping that obviously happened during my time there in Chicago. And as you'll hear in this story, I'm really glad that we're out of that bootstrapping stage for the most part. People don't have to go through typically exactly what I went through in those early years in order to stand up a PCBH model approach. Now, measurement-based care is an aspect of this story that I'm going to highlight because it connects with the future of PCBH that I want to hopefully convince you guys to see. Um, And so while in Chicago, I had, even though measurement was not really a sort of seminal or central part of PCBH as it was taught at that time, and by taught, I mean I got technical assistance from the Bureau of Primary Healthcare at that time. So Kirk Strassel, one of the originators of the model, came out to my clinic and helped me implement the model there, did some shadowing, gave me a manual, things like that to work off of. So I had some structure there. And there was some discussion about measurement, but it wasn't really a core aspect of it. However, even at that time, even in those early days, I did sense that measurement was important, but mostly I tied its importance with sort of proving that PCBH worked, right? That was the idea. And that's not really measurement. That's not really measurement-based care. That's just sort of an enterprise to kind of defend PCBH, so to speak. Nonetheless, I started a rudimentary measurement program while I was there, again, with this idea of just sort of showing our value. And I developed my own database. This was technically before HIPAA. So I cringe at some of the technology decisions that I made that were not HIPAA compliant, at the time. But I created my own database and started collecting Duke Health Profile data and a little bit of PHQ-9 and GAD-7 data. Um, it didn't really influence my clinical work at all. It was just sort of an extra thing to do, right? Just try to sort of demonstrate value. I then, after about 5 years at the Chicago clinic, and I'm glad to say that program is still up and running and doing great. Now they've obviously got a full-fledged huge PCBH program there at the clinic in Lawndale. And some of the people that you see here, I forgot to mention, you're seeing the people here. You probably don't recognize the guy in orange, but that guy is me way back when. Shows you how long ago it was. Because look at that baby face. I mean, wow. And the hair, a lot less gray hair and a lot less thinning. So, and that's my wife to my right there, or on your right. And then that's one of the primary care providers there at Lawndale. And then on the far left is Pat Harad, a beloved person at Lawndale, one of the pastoral counselors that was part of my team there. So, uh, we were bootstrapping, we were learning PCBH. Measurement was not really an important part of what we did. It was just sort of a side thing to kind of defend PCBH, so to speak. Then my family and I, we moved to Madison, and there I started yet another PCBH program at a clinic in Madison, another FQHC. This is Access Community Health Centers in Madison. Once again, I sensed, and especially by this point now, so we're talking about 2006 or so. By this point, COCM had become much more a part of the conversation. And I was intrigued by the way that COCM was able to demonstrate its outcomes, right? And so again, I started a measurement program there, and it was super bootstrapped because literally, I'll just describe this for the fun of it. I created yet another database, and it's an old program. I'm not even sure it exists anymore, called HandyBase. You could create your own database. I got our team of about probably 6, 7 BHCs, iPod touches, which also no longer exist, and had the database on their iPod touches, and clinicians would see patients and then catalog measurement on those touches because our EHR, we were the early adopters in Epic, did not have anything in there that could track any scores. So we literally had to call each other up at a determined time on Sunday evening every week in order to manually submit files one at a time so that I could gather those files, sync those files, and then send the master file, the updated master file, back to everybody manually. And then everybody had to manually upload it to their iPod touches. So we went to some measures to do that. And again, it wasn't measurement-based care. It was really just an attempt to show the value of PCBH, which is not bad, but as I'm going to talk about in a second, that's not what measurement-based care is, right? And it had some results. We were able to actually produce some papers out of that. And I think those papers in general helped to show people that we were serious about what we were doing. And I don't know that it directly led to any funding, but we certainly got good funding because we were seen as a leading program in the state of Wisconsin. So that was that part of my journey. Now, fast forward after about 10 years there in Madison, moved with my family to Chapel Hill, North Carolina, where I am now. And uh, once again, here I'm just starting a PCBH program, but even on a lower scale. This is Department of Family Medicine at the University of North Carolina, and this is now I think 6 to 8 years ago. I forget how long it's been. And I just said to them, "Hey, I lead this national association dedicated to integrated care. I wonder if you guys would be okay with me coming and doing some clinical work because that would really help me in my role as CEO to keep my feet wet in the clinical world." And so that's what I do. I just see patients on Tuesday mornings at the Department of Family Medicine. But once again, a situation where I'm the only BHC or was the only BHC for about 6, 7 years. And I again wanted to figure out a way, and in particular this time around, I started learning the distinction between just sort of tracking outcomes to sort of defend PCBH versus actually doing true measurement-based care, which is like integrating it into your work and making it integral to your work. And so I went on this sort of journey because I said, I can't tell other people to engage measurement-based care if like I don't know how to do it, if I'm not adept at doing that. So for the last couple of years, I've been on this personal journey to actually integrate it into my work and to say, what's going on here that PCBH has not caught up and is not collecting um, uh, uh, measures and not integrating this into the core of PCBH work? What are the barriers? What are the things that I can learn? And what I learned is really, I just had this aha moment at some point in the last couple of years that, oh, yeah, measurement-based care is a skill. And no one ever taught me how to do that. No one sat me down and said, hey, here's how you introduce this tool. Here's how you integrate this into your work. Here's how you make it seminal to your work. Because in all of these other instances that I've talked to you about, myself and the other clinicians did it because we sort of felt like, hey, this is just important to show people our work, as opposed to thinking about measurement as actually something integral to the work we were doing with the patient, right? And that light bulb moment then put me on a journey to learn those skills and to practice those skills. And I'm going to talk about that here in a moment. But for now, the main thing I want you to understand here is that one of the reasons why we haven't made progress in this area is simply because we haven't taught it. Like, no, very few trainees come out of their training programs learning how to do measurement, like how to really integrate it into the work that they do. And so a lot like with PCBH, they need to be trained in their jobs. So here's some sort of take homes. Um, I guess I'm okay with using measurement to prove things, but that's not what I'm talking about here. And in fact, I would argue, I've argued for a long time that PCBH doesn't need defending. The stuff that we do, we all know this, the stuff that we do in exam rooms is not distinct from the stuff that a specialty therapist does in their clinic. We're using ACT, we're using CBT, we're using the same psychoeducation. So if that stuff has been researched, why would we research that again? Right? Like we know behavioral activation works. We don't need to research it just because it's like a different setting and different dosing and titration, right? So I'm okay with sort of larger studies on access and other sorts of metrics that are very PCBH specific, but I don't think we need to defend PCBH per se. We do need to, however, demonstrate its value, and I'm going to talk about that here in a second in very specific ways. And the main argument I'm making here is what I learned in my personal journey is as I engaged measurement-based care, I became a better BHC. So that's my argument here. I think we need to do better at PCBH, and measurement makes us better at PCBH, right? That's my argument. COCM also has ascended rapidly in the last 5 to 7 years. And I will say this till the day I'm dead. There is no competition between COCM and PCBH. I don't understand in my head the competition between PCBH and COCM. There's none. They are two different, they're trying to solve two different problems. And they're both really good. PCBH is really good at solving the access problem. COCM is really good at solving the continuity and quality of care problem. They're both really good at that. And in an ideal world, you have both of them. That's the ideal world, where you've got both running simultaneously. And they work really well simultaneously. So this is not about competitiveness, but that the fact that it has ascended so rapidly, especially in the last 5 to 7 years, I think should light a fire under this community. Because one of the reasons why it has is because it can point to its outcomes, right? So it's going to be integral for us to be able to point to our outcomes if another model of care that is solving a different problem is doing that as well. One of the other things that has sort of lit a fire under me has been our work with helping improve PCBH fidelity. So one of the things we've developed at CFHA is a tool, and actually the tool itself was not developed, CFHA, the training was. But we developed a tool with some work at the Health Federation of Philadelphia called the Behavioral Health Consultant Observation Rating Scale. And we observed clinicians in a simulated clinic through video and gave feedback using the tool. So we have a training now. You can find it on our training experiences page to train clinical supervisors in this tool. And one of the items on that tool is measurement. And one of the things that's clear as day, anytime we observe any BHC on that tool, is that they have no clue how to integrate measurement. They don't know how to talk about the PHQ or GAD-7 other than just looking at it. They don't know how to think about it clinically in relation to the functional issue that they're dealing with in that particular moment. So, you know, again, if you're not being taught it, how would you know how to integrate it, right? It's mostly a procedural thing. And then, of course, as I've talked to my own bootstrapping at the University of North Carolina, taught me that same lesson. I didn't have the skills. I had to actually teach myself and learn some of those skills. And I'll show you what some of those skills are in a second, even though that's not really the point of the talk today. The point of the talk is that main idea. We need to get better at doing PCBH, at being faithful to what PCBH is trying to do. And I use the word faithful because it's not, I'm not arguing that, I'm not arguing for a super strict model, strict definition of PCBH. I am arguing that if we say we're doing PCBH, we should be adhering to its core principles. And there's been significant drift, I would say, in the last few years post-COVID. And measurement is a way back to actually doing better PCBH. So let me just, for a brief moment here, talk more specifically about the skills. There's obviously, this is not a session on learning those skills. In fact, one of the things we're trying to put together here real soon is a training experience for learning measurement-based care and integrating it into your PCBH work. So keep an eye on that. But I want to kind of make this more tangible, right? So I realized that I did not know how to introduce the tools. Like if I was introducing a PHQ to a patient or a GAD-7 or outcome rating scale, like I didn't know how to do it. And I didn't know how to do it at different points in a consult, right? How to do it at the beginning of a consult, how to do it kind of in the middle of a consult as necessary or at the end. I didn't have a good way of introducing what this tool was, why it was important, why it was tied to what we were just talking about or what we will talk about or how we will use it. I didn't know how to integrate it with a key clinical concern. I didn't know how impactful it could be to actually revisit the tool as you're talking with a patient and draw on a certain item. I didn't know that sometimes you don't have to use it, right? To do good measurement-based care, you don't always have to administer a tool because it's like labs. You don't get labs drawn every visit. right? The provider uses it as a tool and then talks to you about it, what it means. And this is so super duper important, people. Listen to this, because this is actually one of the key areas that I see so much drift on with PCBH. I didn't realize how important having observable, quantifiable numbers, how impactful that is for doing good dosing and titration of care. For those of you who've heard me talk, you hear me talk all the time about dosing and titration related to PCBH, because that's where you see the drift typically. You see clinicians drifting into specialty care, and the metric that you can see time and time again is how they are dosing care and how they are titrating care. They're usually drifting back into a specialty mindset, seeing patients back weekly, seeing them back for 40 to 50-minute sessions, and then seeing fewer and fewer folks, and then over time just developing a panel of patients that they're following. And what I learned is that I am better at dosing and titration when I've got some objective number in front of me, or numbers. I can have a PHQ, I can have a GAT, I can have an outcome rating scale number, and I can see, okay, here are the symptoms, here's the functionality, and compare that to my own clinical intuition, my own clinical observations. And I'm then much better at having a conversation with a patient who might want to come back in a week to see me because they just like hanging out with me and like talking to me. But I can look at those numbers and look at my observation and say, you know what? I just saw a patient with a PHQ of 20 and an outcome rating scale of 11. How can I justify to myself bringing this patient back and not having room for that other patient next week, right? So that process of mindfully dosing and titrating care becomes super crucial to PCBH fidelity, and measurement is a really helpful way to get there. So these are all the skills, just some of the skills that are necessary for working with in a measurement-based care paradigm. Now, if you are interested in learning more or diving into or asking questions, we created a chat bot that you can actually just interact with. And you can, as an individual clinician, talk to it and say, help me do better with measurement-based care, and just start a conversation. Or if you're a director, you can actually do the same thing and say, help me create a clinical protocol, or what tool should I use? We loaded it up with evidence-based information related to the top 37 tools used in primary care today in other PCBH settings. And it really does a fantastic job of just giving you a head start to thinking about MBC and integrating it into your practice. So check it out. It's on ChatGPT. You can go to the store and search for it under outcome measures for integrated care, or the link is right there at the bottom of the slide. Now, we are not in the bootstrapping stage for PCBH in general, but we are still at the bootstrapping stage with regard to health technology related to PCBH. And this is another area where COCM has an advantage. There's a lot more tools and support for COCM measurement and tracking than there are for PCBH. And part of that is just the funding mechanism that COCM has. It's different than PCBH. But if we begin efforts to show how important measurement is, again, not just for defending PCBH, but for actually just the clinical work that we're doing day in and day out, I think we have an opportunity to talk with the powers that be at our institutions to help make changes. Like, for example, in my instance, I'm still bootstrapping it at UNC. There's no place for me to put an outcome rating scale score in our instance of Epic. So what I do is I have a section in my objective section of my note where I put the measurement scores, whatever it is, PHQ, ORS, GAD-7. And so since I typically, for follow-up documentation, I just copy in my last note from the last visit with the patient, that prior score is already there. I can add in the next score right there. So not too cumbersome, not the best, obviously, for showing it and for observing it over a long period of time, but it's definitely there. And as for most of you who use Epic, you know that you can also often use a dot phrase for PHQ, pull that into the note really easily, and it'll show you all of the scores, or at least the last 5 scores is typically what the dot phrase will bring in for you and import it into your note. So we're still at the bootstrapping stage from a health tech standpoint, and that is a key finding, right? There is real friction when it comes to doing measurement-based care in PCBH at most of our practices because we do not have the health support. Ideally, health tech support. Ideally, we would have a scenario where before they see us, the patient has already completed a PHQ GAD-7 through the patient portal, through a text link to their phone, or a variety of other strategies like having measurement happen at registration or on iPads outside. There's all sorts of ways to make this so that we're not doing a whole lot of the collection, and all we're doing is sort of looking at the results and being able to track that, right? That's the ideal. We are not there yet. And I just want to acknowledge that that's the reality. So why am I talking so much about measurement when the title of this talk is the future of PCBH? And the reason is because measurement is core to other aspects of our future that is super crucial. We all know that PCBH is not paid for effectively in a fee-for-service model. We know that, right? And the reason that is because what we do as BHCs is not measured best by just the encounter that we have with the patient in the exam room. That's not the entirety of our value in PCBH. Where our job is to impact the entire clinic, where our job is to impact all of the patients that are being seen by the providers through all the curbside consults that we have of providers, all of the in-basket messaging that we do to support patient care, all of the upskilling that we do of our primary care colleagues. All of that is part and parcel of what PCBH is about. It's not captured just in the 90832, essentially, right? And so we know that we want to move and need to move to a value-based strategy, but the problem is all value-based care strategies have to be anchored in some form of measurement, right? And we see this in other aspects of primary care, right? If a value-based care arrangement is made between a provider of care and a payer of care, there's always some measurement that's implied in that, right? Cardiovascular disease. What are your HEDIS measures related to cardiovascular disease? And then that's connected in. So if we're ever going to escape fee-for-service in the primary care realm, we have to have measurement as part of our standard clinical practice. It just has to be there. We just can't avoid that, right? So that's the connection. Now, if we have a solid, faithful PCBH model with measurement-based care embedded, I think we have a really good a way of being part of a health system or a clinic's larger value-based care contracting with the payers that serve that particular clinic. Without the MBC, there's no way to do it. There's literally no way to contract for that. No payer is going to contract with you if they don't know what you're producing, what is the value that you're producing. So those are crucial pieces. And if we look at COCM and how COCM has ascended, and if you were in my shoes and you saw the conversations on a weekly, monthly basis for the last, 2 to 4 years, you will see pretty readily that most of the value-based care conversations incorporate COCM. And unless there's an advocate for PCBH, they don't end up advocating for PCBH. Why? Because there's measurement. That's the simple truth of it. So this is why this is crucial to the future of PCBH. Now, again, I don't want you to lose my main point here, which is that this is also good for PCBH. This actually makes PCBH better. And that's really why I do it at UNC. This is not going to change our value-based contracting. I'm not big enough to even put a dent in that. I do it because it's good for me, it's good for my patients, it's good for how I flow. I miss measurement when I don't do it in my consults at this point. So that is a core part of the future. Now I'm going to pivot here slightly because there's another piece that's core to our future that I want to raise to our attention. And although there is some measurement involved with that as well, it's a slightly different area, and that is chronic disease co-management. Now, this is one of the things that I am disappointed at in my 24 years in PCBH, because when I started, this was the thing I was super excited about. I was like, we can get in there and make a dent, not just with mental health issues, but we can make a dent with some of these chronic health issues that our PCPs struggle with every day. And that promise has not been borne out. We are still primarily stuck with crying patients. That's just a sort of, for those of us in PCBH, we know what that means, right? It's the patients that providers will more readily refer um, because they're just sort of obvious, right? They're the folks with mental health concerns, but they are not referring the folks with cardiovascular concerns. They're not referring the diabetics. They're not referring the folks who um, might need smoking cessation support, lifestyle management support, etc. And that has to change going forward for us in a PCBH world. Why? Because primary care is being pushed in that direction. And we know the golden rule of PCBH, right? Do as primary care does. Primary care is making a hard move towards chronic disease management. It's trying to demonstrate those outcomes, trying to impact core metrics in the areas of diabetes and hypertension in particular. We have to figure out protocols that make us integral parts of that approach, and also convince folks that this is not separate from mental health concerns, right? And again, I'm trying to sort of semi-intentionally create a little bit of competitive envy here, even though again, I will insist there's no competition between COCM and PCBH. But literally yesterday, I got an article come across my desk where they were able to demonstrate cardiovascular benefits to patients involved in a COCM um, uh, program. So, and at least as far as I read, I didn't read the whole paper, but at least as far as I read, they didn't have a specific intervention for the cardiovascular disease. It was just the COCM treatment for depression, and they were able to measure improvements in cholesterol and in what was the other metric that they used? It wasn't BMI. They didn't have any change in BMI, but cholesterol, and then there was some other physical health outcome that they were able to demonstrate. So that's the kind of thing that we need to make part of our work going forward. And very specifically, that really means championing education around cardiovascular disease for our BHCs, and then creating clinical protocols at our clinics to make sure that we're working on those. And again, part of that is becoming familiar with measurement, because in a sense, we then need to be adept at learning what hypertension scores are, right? And how do you talk with patients about that, just as much as a PCP might, or learning how to talk about A1Cs, or etc. Now, we know that there are still significant challenges. So I want to make sure that I don't ignore, I'm telling you to do all this stuff and then ignore the fact that we have some really big challenges in front of us just in order to support our PCBH work, right? As I talk with folks and as I interact with clinics, these are the top ones, but I'm sure there are others. Workforce. Probably we could talk forever here about how difficult it is, especially post-COVID, to build up our workforce. And in an article I wrote a couple of years ago, I really called for a moonshot program. Unfortunately, the federal government is in no position at this point to do anything in this regard. But there's got to be some way because based on my back of the napkin figures, we need about 220,000 BHCs in the next 10 years. Right? So, I mean, that's not a little, right? And I know the issues that each of you have in your areas to do recruitment, to build up training programs, etc. Um, and I'm encouraging anybody, hey, start a training program. If you can start one internally in your organization, that's the best way to create a pipeline just for your own organization. The other key thing that I'm frustrated that we haven't made as much progress in, and again, we're thinking through here at CFHA some possible training experiences that we might want to create here for academics, is that academic training programs have not caught up to integrated care. They still lag. This is why we have the workforce issues. Um, I would have hoped that by now there would be more training programs that had caught the vision for primary care. There are certainly more of them than used to exist in 2001 when I started, where there were zero, but not enough. We need more academic programs that are training specifically for primary care, and we don't have that in the numbers we need. And then I've mentioned the fidelity issues already, right? I mean, we do have fidelity issues, and some of this got exacerbated during the pandemic and post-pandemic, in large part because I think there are many clinicians who have decided that they enjoy telehealth work and want to work from home and sort of use that to slip into more of a specialty mindset with that, or just stopped working in primary care altogether. And that's part of the workforce issue. Um, or folks who just slipped into the specialty mindset during COVID and then just never kind of recovered from that. So I would definitely encourage, if you're a clinical supervisor, take the BHCORS course. It's a good way to get your folks back on track with very tangible feedback using a tool to increase fidelity. And as I've said here, my argument is if you start MBC, it's going to help you actually with that fidelity, especially with your dosing and titration issues. So, all that said, um, so that's just an example. These are some of the training experiences there. All that said, do I feel positive about our future? Absolutely. PCBH is not going anywhere. Like, it's fantastic that in most cases now, when I see legislation, PCBH is named as a model. That blows my mind to someone, who had to explain PCBH to people, um, you know, 10, 15 years ago, in a lot more detail than I have to do now. So PCBH is a part of primary care's future. And I don't think that itself is threatened. Um, but how integral PCBH will be, how embedded in the lifeblood of PCBH will be, I think those things are still up for grabs. And that's where we have to kind of focus our efforts. And I've given you here some pointers. Focus on measurement-based care. Focus on chronic disease co-management. Focus on fidelity to PCBH so that you can demonstrate these outcomes, demonstrate the value, but more than that, so you can just be better. Just be better at what you do as you go about your work. There is, as the slide says, there is still not a demonstrably better way to integrate a mental health clinician into a primary care setting than PCBH. I've often said I am not a PCBH sycophant. In other words, I'm not here to prop up a model. I want what PCBH gives me. If another model comes along that gives me what PCBH gives me in terms of creating access for patients and creating a partnership with our care teams, then I'm going to go with that model, right? I don't follow PCBH for PCBH's sake. I follow PCBH because there's still not a better way to integrate a behavioral health clinician onto a care team than PCBH. So our future is bright, but we have some work to do. And I'd like to light a fire under you because we kind of need to get on it. This is something that especially with federal funding cuts, especially with some of the pressures that our institutions feel. We've just got to get better at PCBH. That's really what it is. It's not about doing extra. We got to get better at doing what we're called to do, creating access, partnering with our care teams, and providing high quality care. All right, that's my soapbox. Let me take a look at the chat here because I saw some things coming through. And feel free, of course, to unmute yourself. All right, so Sandy, thanks for joining, Sandy. Can you talk a bit about the role of the patient and what is measured, what conversations are for acceptance of counter measures or creation of individualized measures of data collection? So the patient is actually integral, and that's a key piece of what I have learned is that when you learn how to have conversations that are actually like not separate from your consult, but actually are centered on what the patient cares about, what you're talking about in the consult. A lot of times the patient will make comments about the numbers as you show them to them. And they'd be like, oh yeah, that makes sense. Or a lot of times it's interesting because I'll ask them about, say, a particular aspect of their function on the scale and say, so is this the reason you rated this low? Is that related to what we're talking about with what's going on with your family? And the patient's like, yeah, that's why that's really affecting me. And that's really important information for me clinically, because as good as I think I am after 24 years, um, I've kind of learned that I make a lot of assumptions. And sometimes those assumptions actually are not incorrect or not exactly on point. And the patient gives me that feedback. It's an opportunity for the patient to give me that feedback. Actually, yeah, you're on the right track, or no, not so much. And feel free to unmute if you want to respond to that. I'm going to just go on here to Mike. Mike's comment here about having a relationship for practicing students and postdocs. Oh, talking about workforce development. Yeah. Yeah, Mike, it's a lot of work. I know it's a lot of work to start a training program, but almost universally, all the programs that have, if you look at your ROI over, I would say it doesn't even have to take 10 years, but like if you look at your ROI within about a 5-year period, it's so worth it. In terms of just hiring people that you don't have to fire or let go of or that leave because they're not good fits, even though they sounded like good fits in the interview process. You don't get that with a training program pipeline. So yes, there's a 3 to 5 year period where there's a lot of work. But then you get the ROI and the ROI persists over time as staff turnover occurs. So if you can, and I know not every setting can, a training program is super huge. Yes, Kane, that is absolutely right. So one of the drawbacks, and it drives me crazy, but the ORS and SRS, you can use those individually. So I use them individually. As an individual clinician, you can use those for free. You just sign up, and technically you have to sign up and get a license, right? But it's free. If you're a program using the ORS, you would have to pay for it. But there are other functional measures that you can look at, and the chatbot can talk to you about some of those measures that you can use to look at functioning. There's things like the HOODAS. I like actually a lot of measures of patient and provider concordance because a lot of the research basically shows the psychotherapy outcome research basically says if you have concordance between as far as goals and alignment between the therapist and the patient, you can draw a direct line from there to outcomes. So the working alliance inventory has a short form that could easily be a great track of that kind of a thing. So you can either do a functional measure and or you can also use sort of an alignment measure that helps you sort of connect to outcomes. Sandy, you've got your hand up.
I'll try and be real quick with this. I have clinically have the regular practice of having patients keep track of their own situation. And we would make up a tracking form that was individualized for every patient. And so they would track whatever the main symptom was that they were concerned about. But we would also track things that we would like to see get stronger as much as things that we would like to see get smaller. And when they would bring back the tracking, I would usually focus on the days that went best and get them to tell me all the dynamics of what that day looked like rather than on the days that were worse. It was a very, very powerful clinical tool. I have not found a way to fold it into the larger infrastructure of measurement. And I feel like if it did, if we could, it would be an example of patient-centered care and partnership with patients that we talk about a lot, but have a hard time delivering when it comes to data. I'll shut up.
Totally agree, Sandy. So, and a good example of that is the youth top problems approach. So this is something I learned during our spring conference on pediatrics, actually. The presenters talked about it. I had not heard of it. And basically, it's a patient-identified it's a way where you ask the patient what the top things are that they want to improve, right? So the top 2 or 3 things. And then essentially it's a way to create a score out of those self-appointed goals. There's a youth top problems. And then you track that over time. Are you making improvements on those goals that you said? So the metric is patient related. And in fact, this is another core learning of measurement-based care that I realized. You really want to compare the patient to themselves. You don't really care about like PHQ with mild, moderate, severe. In measurement-based care, you're not using that typically. Typically, you're just saying, based on what your baseline was, how are we doing? And that's the comparison point. So I think a lot of it, Sandy, is really becoming more we need to like advocate for like just a space in the EHR, right? Because I think you could turn some of those um, that goal setting and those targets that you're using with your patients. You just need a field in an EHR that tracks that thing, right? As long as you can numerically put it in, that's what you need, right? That's where I pointed out that we often are bootstrapping these things because we don't have our institutions that support us to create that field, for example. Like there's no way I'm going to get that at this point at UNC. It's a massive institution giving me a half-day BHC a field.
Thank you.
Neffy, this is Patty Robinson.
Hey, Patty.
Hey, I just wanted to add a little bit to the great conversation here. I've been working in New Zealand now for 7 years, and we don't have some of the barriers. So from the beginning, they were using metrics to assess, in a proof of concept study, and they continue to use them as they've scaled up to have PCBH throughout the country. All of the people working in primary care are trained in focused acceptance and commitment therapy, or focused ACT, which is metrics-based care. So there are 7 measures that are routinely collected all over New Zealand at every visit and provided to the government. And data collection getting to the point of like 60% of visits. And it's enough that they're able to set targets now based on data for the country to pursue. So I would suggest that people look at focused ACT for those metrics. They're very easy to do, and I've had systems I've worked with here in the United States that have integrated them into the electronic health records. It's not that difficult, and they're very clinically meaningful and useful in aggregate as well. The other comment I wanted to make is about workforce, because you're so right about that. And one of the most exciting things to happen in New Zealand right now is the start of a program that is going to be housed in psychology. An undergraduate 5-year program, the 5th year of which is in internships in primary care. So the state license or the country licensing board for psychologists is working with universities, and they've already started pilots. And so this will become kind of you might think of a fast track to BHC Light, and they'll be partnered with BHCs. And the effort includes a career progression so that a person that in 5 years becomes a BHC Light has a clear progression that supports them while working towards becoming a BHC. And yeah, it's very exciting. So I would say, work within your system, but work at the state level um, too, and see what you can do. Thank you.
Thanks, Patty. Unfortunately, it feels like you're kicking a dog when we're down. We're already kind of down on our country, and now we're even more down. We're jealous of New Zealand. And I'm totally kidding, of course, Patty. That's fantastic. I love that New Zealand is starting off learning from our gaps, right? I think that's fantastic.
Well, PCBH is a worldwide movement. It's been implemented in some countries in Europe, and Australia has just released $71 million for pilot studies across Australia and in integrated care. And before this happened, they had someone come, Dr. Paul Fung, come to the United States and visit us, which is what New Zealand did too. That's how I started working with them, because they wanted to find out what we're doing. Australia, like New Zealand, when they looked across the country and they looked at the data, said PCBH fits us better than other models of integrated care. And they went to Europe too. They went to Great Britain,
That's
where
great.
yeah.
Looking at the conversation as well, one of the things I didn't mention, but that bears mentioning, is that we are in the midst of a tremendous transformation related to AI, and that is going to have an impact on measurement. And so getting used to measurement now will be pretty crucial for the future. In large part, and this sort of also relates to Sandy's comment from before, that I I I see a future where measurement becomes a lot more. We all have our qualms with the PHQ-9, right? I mean, like I'm no lover of PHQ-9 here. I think it's good to a degree, but past that degree, it's kind of tough, right? We want to be asking really important questions and that are pertinent to the patient, which I love that you've taught problems approach that I mentioned before. AI has a capability of, in the future, probably doing some out of office assessment of how a patient is doing and giving us some sort of numerical um, evaluation of that is much more sophisticated, that might incorporate questions from the PHQ-9, questions from the Columbia Suicide Rating Scale, questions from a trauma scale or a substance abuse scale dynamically, right? So we may be having that information come to us in a much more seamless fashion in the near future. And again, makes it that much more important for us to become used to that idea in the same way that primary care providers are used to working with their metrics, right? So just something to really think about. I know we're here at the end. I want to just give you some take homes. Like if you've heard anything, just understand this is about getting better at doing what's core to PCBH. And I every time I go talk to people, I say we are not inventing something different here. We are just trying to do really great primary care. That is our goal. That should be our goal. And to me, getting better at PCBH makes me better in supporting my care teams. That's why I do it. So, um, even though it may feel very clunky and bootstrappy, it took me about a year or so before I figured stuff out with my measurement approach, even down to figuring out the laminated sheet that I talked about in the chat. It may take you time to work through that, but investing in measurement makes a difference. It makes a difference for your clinical work. And reach out if you want some support in that area. Look at the chatbot, have a conversation with the chatbot. So that's number one. Number two is, yeah, let's figure out some ways. Let's have a conversation here about how we can help each other do more than just meet the crying patient in the exam room, because we can do so much more. PCBH is so much more. So let's fulfill that promise. My hope is that it's not another 25 years that goes by in my career, and we're still talking about how we're not supporting our primary care providers with cardiovascular disease or diabetes. So those are your take homes today. Thank you so much to the PCBH SIG for the opportunity to use their platform for this. And I hope this can be a continued conversation.
Yes, Dr. Serrano, thank you, thank you for coming on. And thank you to all of you for attending today. We'll have another meeting in a couple months, but thank you so much, Dr. Serrano. We really appreciate it.
Have a great day, everybody.
Bye,
Keep seeing those
everyone.
patients.